Hi, I'm Sarah. I'm a CP3 in psychiatry.
I'm Gurleen. I've just finished my 3rd year of medical school.
Oh, exciting.
Yeah.
When are your exam results?
Oh, already got them. So.
You smashed it then?
I passed.
Yay.
We're going into next year.
Okay.
Yeah,
When did you do finals? Is it in 4th year or 5th year?
5th year.
Oh, okay.
But kind of in January time.
Fair enough.
Yeah. So why did you choose this career in psychiatry?
There was a few reasons really. I was always kind of interested in it at medical school anyway. Like I quite liked the fact that psychiatry is kind of a bit of an interface between medicine and kind of psychology and sociology. And obviously it's a specialty that kind of very much you have to kind of take into account someone's kind of psychosocial situation and the life circumstances in which they've become unwell, because obviously that's such a huge influence on how their illness affects them and also on their recovery. Also as well, growing up, one of my friends suffered with her mental health, and so it was quite interesting to kind of see firsthand how much that affected her and kind of changed the trajectory of her life, not in a positive or negative way particularly, but it was just interesting to see that actually kind of intervening and helping someone with their mental health at quite an early stage can be really helpful in kind of their life and their progress going forward. So that was another thing. I also really valued kind of continuity of care with patients.
Yeah.
So for me, I think even during medical school, the things that I was considering was either something like GP or psychiatry, because you get to see the same people over and over again. Whereas obviously things like A&E, for example, you don't really get to see the same people. It's just you see them on that day and then you never really see them again. So that was another thing that really kind of drew me to the specialty.
Was there anything else you were kind of considering aside from GP, or was it always psychiatry?
As I say, to be honest, I had a pretty open mind during medical school. I hadn't written anything off, but it was just a case of kind of as I did the placements, there were sort of aspects I was weighing up the pros and cons, I guess, of each different specialty, and also, I guess, my own kind of strengths, limitations, what I was looking for, not just in terms of out of the job, but also in the kind of work-life balance as well. And so I kind of felt like with all of those things considered, psych was the best fit for me.
That makes sense. Did you ever have any sort of concerns about becoming a psychiatrist?
Yeah, I mean, I guess for me, the main thing that I was kind of concerned or worried about, I suppose, was the fact, obviously, a lot of the time you're meeting people in potentially like the worst moments of their life.
Yeah.
You know, there's often people might have really significant trauma histories, or they, you know, might be telling you about quite distressing, quite upsetting things. And so I guess I worried about, will I be able to develop the resilience to kind of cope with that aspect of the job? But I think through the training program, you kind of do get enough experience and exposure that you do kind of just build that resilience. And also through supervision with, you know, whether it's you on the job with your consultant or whether it's with your kind of supervisor for the 3 years of training, they kind of help you out and with tips and tricks of kind of how to deal with that side of the job.
Yeah, to be honest, I think that's really refreshing to hear, because as a medical student, I feel like I've had that concern myself, but no one ever talks about it. Everyone talks about how great psychiatry is, and it is like a great specialty by all means, but I feel like those concerns are always there.
Yeah, and I think as well, unfortunately, there is quite a lot of stigma still about mental health. It's improving, obviously, which is wonderful, but I think as well, a lot of people have a misconception that patients with mental illness can be dangerous, and I guess when I was a medical student, having never been in psychiatry, that was something that I was wondering whether that was true or not. But then obviously, when you then start the job and you work with patients, you realise that actually that's not the case, and it's kind of a much safer specialty than maybe I first thought.
Would you say your placement at medical school sort of impacted your decision to do psychiatry?
Yeah, I mean, obviously, I think with anything, you sort of, before you start something or before you have an experience, you might have an idea of what you think it is.
Yeah.
And then the reality when you actually do the placement can be quite different. I had quite a few placements in medical school. We did kind of a community placement, we did an inpatient placement, and actually also I trained and studied at Liverpool, and we have one of the high secure units, so there's only 3 of those in the country. And the kind of high secure unit for the North and Wales is based in Ashworth Hospital. So that was fascinating to me, to work in, you know, a high secure hospital and be able to actually kind of speak to people with kind of significant forensic histories was something that I didn't even know that was part of psychiatry. So
yeah,
I found that really interesting.
That's really unique to be able to do that in medical school as well, because I've had one of my friends manage to do the same, sort of just by knowing a psychiatrist and getting in that way. But it is really cool that it's part of your placement to begin with.
Yeah, exactly. I think like I was a bit of a crude crime fan,
Yeah.
so it was a bit kind of exciting, I suppose, just to see what the reality is actually like, rather
Yeah,
than
of course.
what you see on TV programs or what you read in books. So that was interesting.
Speaking of reality, what kind of surprised you about psychiatry?
Just the variety within it, actually. Like in medical school, I think most of my placements, as I say, I did the forensic placement and then they were general adult psychiatry placements. And I think I hadn't quite appreciated what else psychiatry encompasses. So throughout my 3 years of training so far, I've had placements in learning disability, I've had a placement in kind of child and adolescent mental health, I've had one in perinatal psychiatry, which was something I hadn't even really thought about, but actually, of course, like pregnancy and birth is a really high risk time for people's mental health. And I found that really fascinating. One, because I worked with women kind of my own sort of age, and two, a lot of my friends have been having babies.
Yeah.
So actually kind of even being able to apply what you're learning in your job to your real life is quite an interesting thing to do. So I've quite enjoyed that. And I also did old age psychiatry, and I love old people. So I really enjoyed that placement and being able to not only support the patient, but, you know, supporting their families through really difficult and devastating diagnoses. For example, explaining dementia and that diagnosis and the implications of that to a family, and feeling like you can do that well and you make them feel kind of reassured, informed, and like they've got a better understanding of what's going on, I think was something that I really valued.
Yeah, I think that makes sense. I quite like how holistic psychiatry is as well. Do you have any thoughts on that in general?
Yeah, I think you're absolutely right. You know, obviously we're doctors and we're trained in kind of the medical model or medical management of patients. And yes, prescribing is a key part of our job. But actually, I think maybe more so than any other specialty in medicine, so much of our focus is supporting people with kind of psychological support as well. So whether that's through kind of engaging in different types of therapy, or whether it's kind of, we've got access to a lot of psychosocial interventions, for example, in the community, and being able to give people the resources of what's actually out there in the community that can help support their mental health is something that is really important part of the job, I think. And, you know, in our training, I'd never studied psychology, I'd never studied therapy before, but as part of your core training, you have to do two kind of psychotherapy cases. So you do a short case and a long case in different therapy modalities. So again, that was something that I just found fascinating, learning about that. And actually, it was a whole different side to psychiatry that I hadn't experienced in medical school. So I think medical school placements did prepare me to get a realistic view of what it's like, but also I sort of had additional experiences that I hadn't had in medical school through doing the training program.
That makes sense. Do you think medical schools could benefit significantly more from having more mental health placements and mental health teaching and psychiatry kind of early implemented in its years?
Yeah, I think absolutely. You know, if you don't have an awareness of something, why would you think to choose it as a career? You know, I think what your idea of what something is and the reality can be quite different, as I said before. Funnily enough, I didn't actually have a psychiatry placement in my foundation training. So even though it was something I thought of during medical school, because I didn't actually have a job in it, I had thought to myself, I don't want to pick a specialty without having gained any experience of it. So I actually picked up a locum job for nearly 2 years and rotated around a few different psychiatric specialties just to make sure that I got a real flavour of what the reality is like and what it is like to kind of work with patients within multidisciplinary teams as well, because, you know, that's such a huge part of mental health kind of working, is it's not just you in isolation. Yes, your job as a psychiatrist is to lead the team and you lead on medical management, but also so much of what we do is working with allied health professionals, working with occupational therapists, psychologists. And so to gain a real world experience of that definitely guided my decision to choose psychiatry.
Yeah, that makes sense. How would you say psychiatry sort of differs from other medical specialties?
So as I said before, I think so much of it, yes, you use your science, you use your medicine and apply that clinically, but also there's much more of an emphasis on kind of psychological therapies and the allied health professions as well, because that often, you can give patients choices a lot of the time as to, well, which route do you want to go down, or do you want to make a use of kind of a combination of both medical and psychological treatments?
I know a lot of people who kind of think about doing psychiatry, especially as a medical student, might have concerns or worries about losing sort of the medical nature of the degree. Do you have any kind of thoughts about that? Or
yeah, I understand why people think that, because, as I said, so much of the job is the kind of psychological side of it as well. But actually, when you're on an inpatient ward, as particularly in the core training years, a lot of the patients are with you for weeks and sometimes for months. And so actually they don't have access to their GP necessarily whilst they're an inpatient. So actually a lot of managing the day-to-day physical health issues that come up on the ward, it's actually the junior doctors that are predominantly leading on that. And also a lot of our patients, they all require bloods to be done on admission, ECGs to be done on admission, and prescribing. So you still are very much using your medical knowledge, and it's still very, very relevant. And a lot of psychiatric conditions also impact on patients' mental health. So, whether that's a physical health condition that they have, or just their kind of engagement in their physical health. So whether it's, if they're depressed, they might have self-neglect, that kind of thing. I think mental and physical health are very much at an interface in psychiatry. And so I can see why people have a misconception that they might not use their medical skill. But I think that's actually quite false. And you rely on your medical training a lot during your psychiatry.
Yeah, that makes sense. Do you have a particular subspecialty that you're interested in?
I'm still deciding. The things that I've enjoyed the most, I think, as I say, I actually was lucky enough to do a 6-month post in therapy, which not all trainees get to do, but I was lucky enough to do. And I absolutely loved it. It was a completely different way of kind of formulating a patient's kind of condition and the way they thought about it, and kind of gaining more insight into the psychological aspects that feed into why they think the way they do, why they behave the way they do, and how that impacts on their mental health was something that I found really fascinating. And as I said before, perinatal, I'm not a baby person, so I didn't think I'd enjoy it, but I actually really loved it. It's a really well-resourced area to go into, and it's actually still quite new. It's not actually got an official training pathway yet, it's that new. But you can do that by training in general adult psychiatry and then choosing that as a subspecialty.
Okay. I feel that's a very sort of developed, unheard of specialty, because even I had only just heard of it recently, but I feel like it's really, really interesting, especially in the way that kind of women's health and menopause and hormones and all that play into sort of different psychiatric conditions and things. So I think that's a very interesting one.
Yeah, I think so. And also it's so applicable to so much of the population.
Absolutely.
You think how many people are parents, how many, and I think also being able to support fathers in helping them support their partner, or whether it's, I think that's an area where it's been quite stigmatized in the past, and actually helping women to feel like it's okay for them to struggle at that time, and actually being a mum isn't just something that because you're having a baby you just naturally are able to do.
Yeah, of course.
It's actually, a skill that a lot of us need to practice to learn. So supporting someone through that and giving them the confidence to be able to feel like they're doing a good job is really invaluable. I found that really rewarding.
So what can I kind of expect from a first year as a core trainee?
So core training is a 3-year training programme. In the first year, most people, in the first 18 months of training, you're expected to do 2 general adult posts and 1 old age psychiatry post. And within that, at least 6 months has to be community-based and 6 months has to be inpatient-based. So obviously some people end up with a year of inpatient, some people end up with a year of community. But it's a quite good grounding to kind of get you experienced with obviously kind of common presentations that you see in mental health. And also kind of you start to then specialise obviously with the old age psychiatry, but that then gives you a really good grounding to then start specialising more. So in your second and third years, you may then get more specialised placements, so things whether that's child and adolescent psychiatry, learning disability, and then in your third year of training, you have a bit more capacity to kind of have slightly more kind of niche placements. So sometimes it could be things like forensics, eating disorders, perinatal placements, that kind of thing. So as I say, there's a lot of variety, but it's quite good in that it's kind of mandated that rather than starting off in something that's incredibly specialist, you get a good grounding in general adult psychiatry for the first year.
That makes sense. And what kind of things are you doing on the job?
Yeah, so obviously as an inpatient job, I guess, sort of similar to a foundation doctor where a lot of the time you're being supervised by your consultant, but you are doing ward rounds with patients, you are potentially making decisions about changing medication. A lot of inpatients, when you first get there, if somebody's on a section, they might have some restrictions that kind of limit their ability to come and go as they please. So it's sorting out, making decisions as to when that can be kind of relaxed and what level of supervision people need. And I think as well, obviously, as the junior doctor, you're often on the ward, you're more of a ward presence, whereas the consultant might end up having to cover multiple wards, that sort of thing. So you're kind of the continuous member of staff for the other members of the team as well. So I think often the nursing staff, for example, may be more likely to ask the junior doctor for advice or for your opinion or to come and review somebody who's acutely unwell, rather than necessarily jumping straight to the consultant. So it's good in the sense you get opportunities to take on responsibility and lead the team, but also you are well supervised from senior colleagues, which I think maybe more so than some of the other placements that I did. I think when I did surgery, often the seniors are physically in theatre, so you feel a lot less supervised maybe day to day than I have done in psychiatry.
Yeah. And in terms of kind of the job itself, what would you say are the sort of more demanding aspects of it?
The most demanding things I think are just obviously it's really emotional a lot of the time as to what you're talking to patients about, and it can be quite a kind of heavy emotional burden, and being able to try and support people through that. I think in order to be a good psychiatrist, you need to have empathy, you need to be caring, you need to be genuine. But with that comes, you really feel for your patients and want to help them in the best way that you can. And obviously, if there's kind of medical and psychological issues, you want to do that. And also trying to help with the social issues as well as much as you can is really rewarding. I also think another side of it that people don't really talk about, but is obviously really important, is suicide. Unfortunately, suicide is a facet of a psychiatrist's role, as you will inevitably have patients who end their life. And I think that can be really tricky, and it's sad when anybody dies of any cause, but I think kind of culturally and socially, suicide just feels that bit different, where somebody has made a choice to end their life. So I think that's something that is really hard. But again, when that has happened, there have been a couple of patients during my 3 years of training so far who have ended their life. It's a really supportive environment, both for the relatives of the person who's ended their life, but also within the multidisciplinary team. You're never working on your own as a psychiatrist, it's always multidisciplinary, and being able to be supported by your colleagues, you've all gone through that same experience together, I think is something that is really invaluable. And I hadn't thought about at all as a medical student. And then when it happened, I was so grateful to have the team around me that I did. And obviously, along with that comes the kind of legality side of psychiatry, which again, I wasn't especially interested in law, particularly prior to doing psychiatry, but there is a lot of interface between legal matters and mental health. And so for anyone who's interested in kind of the legal side of it, and you get a much better understanding of that as a psychiatrist. And often you have to attend, for example, inquests, write statements for the coroners. Again, I had that sort of experience when I worked in A&E, but the support that I got from seniors in helping me draft the statement, how to word it, and kind of talked through what the process would be of being asked to do a statement by the coroner and potentially attend an inquest was something that, again, compared to my friends who were in other specialties, I felt like I've had a lot more support through that, because I guess in psychiatry, they're more prepared for the fact that that is maybe more likely to happen just by the very nature of you're dealing with people who are acutely mentally unwell.
Yeah, I think it's really important to talk about suicide within the career as well as the emotional impact that psychiatry can have. Do you mind kind of talking a little bit more about your own experience with this and a little bit about how you manage your own mental health?
Yeah, and I think that's a really valid question, isn't it? If you spend all day talking with patients about how to manage their mental health, it makes sense that you should try and take your own advice as well. So I think, maintaining a good work-life balance is essential. Putting your all and trying your best while you're at work is, you should take pride in what you do and enjoy what you're doing. But I think it's also really important to maintain interests and relationships and hobbies outside of work in order to kind of offset and kind of diffuse some of that stress. I myself, I'm into horse riding and I like swimming, but whatever it is that you're interested in, whatever helps you to de-stress is really helpful. I also think within the training program, in the first year of training, there's something called balance groups, which is kind of a reflective space where a group of CT1s led by a facilitator with experience in psychotherapy, you actually debrief difficult situations or difficult patient interactions that have either brought up strong feelings for you or you found particularly difficult. And the focus of that is not to focus on the medicine or the clinical case, but it's actually to focus on your own emotions and kind of explore in a group setting why it may be that interaction brought those emotions up for you and what does that mean and how can you best manage them. And I think that's in the training program in order to help you develop skills that you then later need to use in psychotherapy, when a lot of psychotherapy is kind of being aware of the concepts called transference and countertransference, but essentially the dynamic between yourself and the client, you need to be attuned to that. And I personally have found as well, the training that I had in psychotherapy, I've been able to implement in my actual day-to-day consultations, even after finishing that psychotherapy post. And I hope that's kind of made me a bit more of a kind of reflective, compassionate and insightful clinician.
Yeah. This might be a bit of a tricky question, but how do you sort of balance having empathy without taking too much on yourself from what your patient is saying?
It's important to be empathetic, and I always think, what would I like my if I was in this situation or my mum was in this situation, what would I want from services or how would I best be supported? So I always try and emulate that in consultations that I have with patients. But I also think being able to kind of debrief or being able to kind of talk to people about when you are struggling and seeking that support early is something that's really helpful. And I think that can be sort of more formally in things like balance groups or, in the psychiatry training, you also have allocated supervision. So you will have an hour a week, one-to-one with your supervisor, which again, I don't know if that's common in other specialties, but that's something that is kind of mandatory in our training. I think that's really helpful to help you kind of navigate how to cope with psychiatry training, I guess. Speaking to your supervisor who's been doing it for many years, they will have a lot of advice and help and support to help you then develop your own ways of dealing with the job.
So you've spoken about kind of supervisors and balance groups. What other support is available for you as a psychiatrist and a trainee?
So as I say, there is that kind of formal support. I think also as a trainee who has a disability, there's also support with regards to reasonable adjustments. So I was encouraged to kind of have an occupational health assessment as soon as I started training, and adjustments were made in terms of the physicalities of the work environment, but also with regards to our exams. In psychiatry training, in the 3 years of core training, you're expected to complete 2 papers and kind of a more practical exam called a CASC, which is like an OSCE. And as soon as my supervisors were kind of aware of my disability, they encouraged me to contact the college and explain kind of why I'm a need reasonable adjustments, and it was a really straightforward process, and I was granted reasonable adjustments for exams. So I think that was something as well that I'm sure that probably is available in other specialties, but I felt really relieved and really supported that was present in psychiatry training as well.
Do you have any advice for someone like myself, a medical student who might want to go into psychiatry?
Yeah, I think the most important thing is to try and gain as much experience as you can, whether that's going onto the wards, whether that's working in the community, or even, volunteering at groups in the community as well can be really helpful. And I think having a really open mind when you do the placements is something that's also really important, because I think often whatever you may think it will be in your head, I can guarantee you it will probably be quite different. And so just appreciating all the different spectrum of what you can do within mental health would be something really important to keep in mind, for sure.
So you mentioned about exams and things like that, and I know it can be really difficult sort of being on placement, doing your job, and also trying to learn all the content. How would you sort of manage that in your...
Yeah, so I think, obviously having done a medical degree, we've all kind of learned how to fit revision and things around placements. But I think something that I really value about the core psychiatry training program is that we have kind of 4 hours a week of local teaching time that is completely protected. So you always get to go every week for the full length of teaching. And then in addition to that, there's also kind of a teaching day roughly about once a month or once every couple of months, where it's actually a regional teaching day. So it's really nice where you get to meet it's face-to-face in the deanery that I work in, so you actually get to physically meet people from all over the deanery, which is really lovely. And I think often, different regions may have different ways of working or different types of patients, different demographics. And so being able to kind of chat with your colleagues and pick up each other's kind of learning experiences and tips and tricks, or just things that they may have encountered that you haven't yet, helps kind of prepare you for your clinical work as well. So I've really valued that, where I think potentially it's not always as easy to kind of make sure that you get to teaching when, for example, if you're on a busy ward in an acute hospital, it can be difficult to sort of try and get away from the ward to make sure that you attend the teaching. So I think I really value that about psychiatry. And I also think there's also a lot of opportunity where if you're interested in medical education, you can get involved in that either at a local level or at a regional level. And that can be really helpful in terms of applications for your higher specialty training. There's always points on applications for things like getting involved in education. I myself was lucky enough to do kind of an educational simulation fellowship with NHS England during my training. So that was something that was kind of above and beyond. The average core trainee wouldn't be expected to do that, but those sorts of opportunities are available if you're interested. And so that required me to go to less than full time with my clinical work. So I went to 60% and spent 2 days a week for 12 months working on medical education, which I really valued.
And what sort of things would you advise as kind of medical students, foundation doctors, junior doctors to do to sort of strengthen their application for psychiatry?
The main application when I applied was that you sit the MSRA exam, and obviously try and get the highest score that you can, as with any of our exams. And other than that, it's just making sure that you get the experience, whether it's through placements. You can always get in contact with the local psychiatrist to see whether there's any audit projects or any kind of quality improvement projects going on that might be related to psychiatry. I managed, when I was in A&E, I wasn't particularly interested in A&E, though I did like the variety of it. I chose to do an audit on patients presenting to A&E having taken intentional overdoses or engaged in deliberate self-harm. So, even if you don't get a psychiatry job in your foundation training, you can still find ways to incorporate kind of a psychiatric spin, I suppose, on the placement that you're doing. I think a friend of mine as well, she, while doing a surgery placement, did a quality improvement project, or I think she did a primary project actually looking at the psychosocial impacts of pancreatic cancer. So again, if you're on something that's completely unrelated to psychiatry, I think there's always a way that you can think about getting involved in a project with a psychiatric twist.
Okay, that's really helpful. I think it's handy that psychiatry overlaps so well with every other specialty in that way.
Yeah, of course.
Yeah.
I think anyone who's ill for any reason is probably likely
Of
to
course,
be
of
affected by it, aren't they? Whether
Absolutely.
it's with their psychological or social issues. So.
What would you say is sort of the most surprising thing you find about psychiatry?
For me, I really value the culture within psychiatry and the culture in psychiatric training. And what I mean by that is when you're on call, for example, and you've managed a clinical situation as best you can, but you're at that point where you think, oh, I'm not sure what to do next. Whenever I've actually had to call and ask a senior for support, whether that be a registrar or a consultant, they've always been so incredibly approachable and grateful for you calling and willing to help and give you advice and support. And I think feeling like you're not in position, being in imposition or kind of putting them out is something that I really valued. I think to feel safe to ask for help when you feel like you're out of your area of competence is something that is really important in medicine in order to practice safely and deliver the best quality of care that you can, but also feeling that you can do that and you won't be kind of judged or looked down upon for it is something that, again, I think a lot of trainees worry about that or think, will my seniors think I'm incompetent if I can't manage this by myself? But actually, I think everyone in psychiatry knows that, as a junior doctor, they expect you to not always know the answers and they would much rather that you ask for help and they can help you than you worry and panic by yourself.
Yeah, that's definitely really important. I would say for myself as well, even the support and just meeting anyone from the college as well, it's just really sort of strengthened the fact that I want to go in this field as well. So I think that's really good.
Perfect.